So let us move forward in this program. I am honored to introduce the moderator for today's last panel, Martha Cameron. Martha Cameron serves as the Deputy Director, yay, of the National Working Positive Coalition. She is originally from Zambia, Africa, and I had the opportunity to see that part of the world, and it is beautiful. If you have the opportunity, you must go. Where she was born and raised, and is a long-term HIV survivor. Most recently, Martha worked in executive management roles for the International Community of Women Living with HIV, ICW North America, and the Women's Collective in Washington, D.C., both leading community health, human rights, and advocacy organizations in Washington, D.C. Martha is actively involved in various other HIV policy advocacy and research forums, including the Positive Women's Network USA, U.S. People Living with HIV Caucus, DC Center for AIDS Research, and I can't tell you, please get in touch with Martha about the research parts. They are doing some dynamic work there, and Georgetown University. She has a bachelor's in education and a master's in public health. Martha is now going to moderate a panel which will highlight research studies related to HIV and employment. Go ahead, Martha.
Thank you so much, Vanessa. Appreciate the introduction and just an amazing welcome to everybody that's here. I'm so excited to be moderating this panel on research. I am so grateful to have heard from Harold Phillips, and he specifically mentioned research and how sometimes it takes a long time for it to impact policy or services. But I'm also just really amazed by both panels that have just preceded us, because they really do highlight some of the challenges and real life experiences that we face. I won't waste too much time, because I really believe that this is such an important part of the conversation as well. And I was so grateful when I joined NWPC to find that they had such a big focus on research, and are working really, really hard to make sure that this impacts not just policy, but day-to-day lives of people living with HIV. So we have an amazing panel. I will introduce them all very quickly, so that when it's time for them to speak, they can just go ahead and share some of the important things that they're going to share with us. Dr. Jen Chu is an assistant professor and program leader of the Clinical Rehabilitation Counseling at Hunter College, City University of New York. She's a certified rehabilitation counselor, and her research interest focuses on vocational rehab and career development for people living with HIV. She serves on the NWPC Research Working Group, and we'll be sharing a little bit about that for context. Dr. Liza Conyers is a professor of rehabilitation and human services at Penn State University, and she co-chairs our research working group with Dr. Chu. She serves on the Pennsylvania HIV Planning Group, where she chairs an ad hoc committee on HIV and employment. She's also on our board and is our deputy chair with Vanessa Johnson. So we have a really powerful board of directors. Dr. Atiya Khan is a postdoctoral fellow in the Faculty of Health, York University, and this is in Canada at the University of Toronto and York University. She's an internationally trained medical doctor and has a PhD in health policy and equity. Dr. Khan engages in community-based research focusing on immigrant and racialized youth mental health, young adults, and developmental disabilities and maternal health care. Farbod Poor, who is a licensed counselor and is getting our prize from being the furthest away in Iran. His work has revolved around advocating for social determinants of health, with a specific concentration on enabling communities, employment, and advocacy for people living with HIV and the LGBTQ communities in Southeast Asia. He's dedicated his efforts in bridging the gap between healthcare and employment services to ensure that people living with HIV have the opportunity to live fulfilling lives. Both Farbod and Atia will be helping us, draw parallels from an international perspective. And last but not the least, Sangwon Yon Lee is a PhD student in counselor education program at Penn State University, and Sangwon has been working as a counselor and advocate for the LGBT communities in South Korea. His research interest focuses on advocacy education for counselors in training, professional development, LGBTQ plus counselors in training, and minority stress coping strategies. So just amazing background. Everybody really sort of keen to work with the different aspects of our community. For our workshop today, or for this part of the panel, we want to really understand employment barriers for people at risk for and living with HIV, and the role of counseling and socioeconomic support in reducing barriers for people that are for employment, people living with HIV. So without further ado, I'm going to ask Jen to introduce and share the mission and goals of the research working group. And this is with the idea that I know some of you on here are counselors or counselors in training, and it would benefit you a lot to be part of our research working group. So we'll share the links for those that may be interested. Go ahead, Jen.
Sure. Thanks, Martha. And hello, everyone. This is Jen Chu. I'd like to give you the overview of our research working group. So the NWPC Research Working Group was established in 2003 by Dr. Conyers and a group of researchers and people living with HIV. I joined the group in 2008 and became co-chair with Liza in 2017. So our mission is to promote the practice. Oh, sorry, Martha, can you advance the slide?
I was just texting Heather
Heather.
for
Okay, great.
control of our slides.
Okay.
So we're on Jen's slides, and I'll be sure to say next slide, Heather. Sorry,
Okay. That would be great. Our mission is to promote the practice of research for the development, facilitation, implementation, and evaluation of strategies and interventions addressing the employment needs of people living with HIV or had a greater vulnerability. We also focus on many factors the previous panels already discussed, such as poverty, incarceration, mental health, and housing issues. We also examine the role of employment as a social determinant of health and explore the impact of employment on quality of life and health outcome. I'm sorry, I think the slide is off. It will be the previous slide. It's after Jen's section.
I think the slides are kind of moving ahead. If we could go back.
Yes, okay, yeah, you can stay on this one for now. And for our research working group, we have three primary goals. I'm sorry, the previous one, the previous slide. Yes. So the first goal is to advance research on HIV, vocational development, and employment. We work with researchers across US and internationally to discuss current trends of research. We also support interdisciplinary collaboration to discuss relevant research questions. Our research group of different disciplines such as counseling, social work, and public health. The third goal is to inform HIV care and prevention policy development. We often present our research findings to policymakers and other stakeholders to provide recommendations. Next slide, please. So what do we do as a group? We meet monthly to foster research collaborations. Our members will discuss our current research project and see if there's any opportunity for collaboration. We also share research finding at research at conferences, trainings, webinar to raise the awareness of the field. Here are some examples of our recent projects and initiatives. So the first one is we develop a bibliography on HIV and employment. This is like a library, include a lot of articles, research study. You can find this on our website. They will provide a lot of ideas. We are currently updating this library and working on a systematic literature review project. We also developed a book chapter together, Employment as a Social Determinant of HIV Health, Care and Prevention Outcomes. This is a public access book, so everyone should have an access to this online book chapter. In 2021, we also host a national convening on HIV employment. So a lot of our research working group members present their research at the convening. And also we conduct a national project. It's the first national survey on employment needs. So this survey, we collect more than 2,000 responses from people living with HIV, and it demonstrates tremendous need for employment services. We found underutilization of vocational rehab services and other employment services among people with HIV. So then we conduct a follow-up study in New York State, partnering with the AIDS Institute during 2020 to 2021. This was also during COVID. So we also found there's significant impact of the pandemic on people's employment status, quality of life, and also their interests maintaining and pursuing work. Individuals also express need for job search assistance, career counseling, and benefits counseling. So I'm gonna post those links later so you can have access to our articles and recent projects. Now I'm turning over to our colleagues who will discuss key findings from existing research studies. I'll turn it over to, is there someone?
Yeah, it's actually going to be Atia.
Atia, yes. Okay.
Okay, great. Thank you. Thank you, Martha, and thank you, Jen. And I'm going to start by thanking the organizers of the 5th Annual Career Institute for inviting us here to speak about this research that we are conducting, our team is conducting. So I won't spend more time on that. I'll just try to dig straight into the research and the findings that we are coming up with. So as Martha explained.
Sorry, Heather, could you
Yeah, so I think you need to move on to my slides. Yeah.
They're ahead.
You'll see this little blocks.
Okay,
Yes, after this.
Right here.
Yes, if you can move on. Yes, this is this. Yes, perfect. Oh, the back. Yes. So this is my first slide. So I'm going to be speaking from the perspective of what we have in Canada, how people with HIV/AIDS and what the literature around employment and HIV/AIDS says in Canada. So the first slide, as you can see, speaks about the barriers to attain or maintain employment. So this is coming out from a study that was evaluating employment assistance programs for people living with HIV/AIDS, people from Toronto and Ottawa. So it was a mixed method study, but there were several papers coming out of that study. And as you can see, I've organized them according to the micro, meso, and macro level. Factors that impact employment. And the reason is that it's easier to digest in the, what I'm going to be discussing. So as you can see on the left, at the personal level, stigma and discrimination when seeking work were significant. So people anticipated that if they were to go for a new job or if they were seeking employment opportunities, they feared that they would have to disclose to the employer or their peers, and that might impact their termination of their contract. Mental health was, again, a significant barrier to seeking employment, specifically because people were feeling anxiety, depression, and especially like being around other people when taking public transit and even going for an interview for employment. They also felt less confident when they would, come face to face with the employer, even with their peers at work. The next, moving on to the meso level, as you can see, the top, it says relationship building with the employment counselor. So there was a dearth of employment counselors, and they felt that, every time it would be difficult for them to start rebuilding that relationship with their counselor. So that was highlighted in the studies. And beyond that, they also felt, although the employment counselors were doing a great job in trying to help them get employment, but the problem was that their help or whatever, it would not really influence the employer's hiring policies. So that's what they felt, that that was a barrier as well. Going on to the macro level of barriers that impacted these individuals, and from the studies, they mentioned that navigating the social assistance program in Canada. We have the Ontario Disability Support Program. That's for people who have some kind of a disability. The government provides them with the benefits, and there's also unemployment insurance program that exists in Canada. So people had difficulty navigating them. It wasn't very clear. It wasn't very transparent. And although these programs are there to help these people, to help them to be, to manage their expenses or the income, they felt that these were like a trap for them. They were putting them in a trap of poverty or a cycle of poverty by creating all these barriers. Barriers to acquiring stable and adequate income for themselves. Because they lacked flexible employment opportunities, people wanted to work, and they had a desire to work, but because of their episodic illnesses, that they wouldn't be able to work, and then they had to be out of these programs. And I'll explain what and why. And so each jurisdiction in Canada, they have their own policies around how the earnings and employment would be treated or clawed back. And so people had the fear of, losing those benefits and that income as well. So next slide, please. So this is a slide that comes out of the findings from another study, and I think one of the presenters earlier mentioned about. No, I need to go back. Yeah, please go back. This one, yes. So this is in context to somebody. I think we had one of the presenters talking about a bigger cohort of people who are older and they are living with HIV/AIDS. So this just fits into that discussion. So neuropsychological test performance was used by these researchers to predict occupational outcomes. So older people who are asymptomatic, they have HIV/AIDS, but they're asymptomatic, and they may develop this HIV associated neurocognitive disorder. It's called HAND. And different types of neuropsychological tests are used to assess the cognitive impairment in people who have HIV hand diagnosis. And what they found is that there was no association between using this test to diagnose cognitive impairment and a decreased productivity at work. So the authors argue that there should be better testing tools or scoring methods to be able to tease out cognitive impairment in these people. So it's okay, but sometimes some work positions may require more cognitive tests. So that's where we need to be more clear about this. Can we have the next slide, please? Lastly, I'll kind of bring it all together and speak about the different recommendations that come out from these studies. So I'll start off with the macro level again. So I'm going to talk about the upstream factors, how we can kind of change that. There is a need for reform of social assistance programs. There is need to advocate for policy change that supports people who are re-entering into the workforce and those who are exiting the social assistance program, the disability support program, and how they can go back and move back and forth from these programs. So we need to support the workforce entry and retention of those people. And the social assistance program needs to be more flexible around providing them assistance. And there needs to be more transparency around the regulations and the paperwork, etc. Next, again, there's a need to address the structural institutional stigmatization. So this is not just limited to the employment sector or the health, not just the employment sector, but the health sector as well. There's need for more coordination and integration of existing programs that target people living with HIV/AIDS, so they are able to enter the workforce. There are some programs that are running in Canada. These are just beyond what the government offers. So there we have the AIDS Committee on Toronto, the Employment Action, etc. And we also have the Black Coalition for AIDS Prevention. So there are different programs that assist people living with HIV/AIDS to re-enter the workforce. There's also need for integrating mental health supports into these programs so that people are able to continue taking their ART medication, their medical benefits, regardless of their employment status. Then moving on to the service sector. So how can improvements be made in the service sector level? There is need to provide more technical training and education. And one thing that was really specifically highlighted in the study was that participants also felt that, the preparation that they provided for taking up jobs was not really tailored to their needs or whatever skill sets that they brought. So there is that need for each preparation for job employment to be tailored to themselves. There's also a need to have more visibility of people with HIV/AIDS part of the program staff. So they feel that, they weren't able to connect with many of them, the people who are serving them. And they also felt that they were kind of not, forgotten in a way. So service providers need not to abandon them. And, once they are hired, they should at least, check on them and, follow up with them. And I think that's great. I will not take up more time, and thank you so much.
Thanks so much, Atia. And I really do encourage people to sort of put questions in the chat, because what we're going to do, and I should have said at the beginning, we're going to go through all the presenters first. And so it will be a lot of information to take in. But I would really like people to be thinking about, what sort of the research is saying, and what it means. And that's why we really wanted those recommendations, what it means for services, especially in terms of employment for people living with HIV, because already we've seen, even though Atia was speaking from a Canadian context, we could already see that these are things that are needed even here in the US in terms of, what is happening to us mentally, and our cognitive stuff, and how that affects our employment. What support and services do we need? How do we integrate, these rehabilitation or support services for people living with HIV going back into the workforce? So I encourage the comments and the questions in the chat, but for now, we'll move on to Sangwan.
Hello, I'm Sangwon Lee, and I'm a counselor, so I might focus a little bit more on the counselor side. And so I will talk about a little bit of like career development and also employment among the like gay, bisexual, and other men who have sex with men living with HIV. So next slides, please. There can be some overlaps, I think, among this, like the articles, because most of them are focused. So our articles are like, these are the part of our systematic review project, and our systematic review is focusing on the like experiences of people living with HIV. So a lot of like challenges and the like barriers that can be faced by people living with HIV might be, there can be some common ground among the studies. But I'm focusing on the gay, bisexual, and MSM population for my presentation. So there is some studies like here that focusing on the gay, bisexual, MSM. And in 2020, Deans and colleagues study they see the like how employment is affecting their like situation in their lives, and So they found that the 12% less likelihood of being employed for the people living with HIV, gay, bisexual, MSM living with HIV. And maybe can be linked with the 9% more likelihood of a financial difficulty they can have. So employment is important, but at the same time, there's also a barrier to access and then get employment, get employed in the field. It was also can be not, it can be challenging for the gay, bisexual, and MSM population, and also a financial difficulty. We can think of like linking with the employment or like difficulty to be employed in this field. And but employment is also important psychosocially, but also for their like managing the HIV health. So like you can see here, they found that the people who were employed has a 6% less likelihood of like immunosuppression, and also like less likely, 32% less likelihood of progression to advanced stage in HIV, which is AIDS. So employment can have also impact on their viral status. And that study was not specifically focusing on the certain racial ethnic group, but a 2021 Mosby and colleagues study, they're focusing on the Black MSM groups and found that, we can change the numbers here. So 60% less likely to be employed, particularly the full-time jobs. So most of the people like saying that like if they have a job, they're a part-time job, then of course like they also mentioned I didn't put it in here, but they also mentioned about the challenges to getting a job and getting employment regardless of like full-time or part-time. So there's also intersectionality we have to consider when you're thinking of our clients' experiences and their career development. And also these are all like intersectional studies, which means like just the one chapter in their lives. But there's also one longitudinal center study with like multi-center cohort study by Ware and colleagues in 2020. And it was interesting because like employment status was affecting their depression after 2 years. So it can have a long impact on their lives, like in this aspect of the mental health. So employment is linked with like we said, their viral status, but also mental health, and of course the financial status too. So it can be really impactful, and then we have to be. So I'm glad that we are talking about this at the Career Institute, and I'm linking with the importance of the services. And can you go to the next slide, please? So now I'm moving more focused on the counselor's role. So Dispenza and colleagues study in 2018. They did the qualitative study with the people living gay, bisexual, MSM living with HIV, and particularly like how they navigate their challenges and barriers in terms of their career development. So they found out that most of their participants were like they experienced the moving forward within this like social political oppressive environment. Like they had to deal with the social factors, which is like homophobia and all the like minority stressors they had to deal with. But at the same time, they also have to deal with a lot of other aspects, such as like health related, also the latter like psychological aspect like mental health, like we talked about the depression, so depression wise and other stuff too. So the implication for the counselor, they said, was intersectionality. We have to think of like MSM living with HIV when they accessing to the services, like, how the counselors are trained as a affirmative, like, affirmative counselor, and also cultural competence to understand about their cultural background and the social political context that they're living in the United States. Of course, like it can be also transnational experiences, and also uh, it can be tricky for the counselors because sometimes it seems like we're out of the scope of like our professional roles, but they stay emphasizing on familiarizing themselves with the affirmative human services and medical health referral agency. So we cannot only stay on the counseling rooms, but also have to think of other kinds of services the clients need. Sometimes it can be medical services, but of course, like vocation and rehab, like other human service case management, a lot of other roles might be required. And for their career, like driving force in their career development, they're focusing on the intrinsic, extrinsic, like motivations. For example, like focusing on what is their purpose, the meaning of like pursuing the career in their life as a people living with HIV. And like a lot of barriers can be there also, but at the same time, they have their own goals, like their own meaning in their life, of focusing on them to like going through the paths they need. Next slide, please. So I want to bring up like because we all talking, even though like I know a lot of people here will be counselors or counselors in training, and maybe think of like counselors' role is focusing on the individual, but like as you know, American Counseling Association has been focusing on the role as an advocate also. So they also offer the competencies like model, and you can find it in the ACA website. So we're not like only focusing on the people in the clinic room, but we also need to know about what we can do outside of the clinic. Maybe sometimes go to the community and also be familiar with all the services multi-layers outside of the counseling room. Okay. Thank you.
Thank you. Thank you so much. And I'm really glad some of this we're hearing is coming after we had the panels because you really kind of hear what is going on with the lived experience, right? Like people do not live single issue lives. And so when counselors are approaching people living with HIV, they're thinking of all these other things, this intersectional things that are going on. And of course, we have heard, especially post-COVID, but even before that, how depression and mental health has really, really impacted our community. So we'll keep it moving, but if you have any comments or questions, I'm really encouraging you to go ahead and put it in the chat. And now we're going to hear from Farbod.
Hello everyone. First of all, let me check. Can you hear me?
Yes, we can.
Yeah, all good. All right. So I have to always check the sound as I'm very far away. So it's difficult sometimes with the connection. So, well, what an honor and a pleasure to be invited to this amazing panel. And actually, as I've been sitting here, I've learned so much from what's going on, and great previous panelists. When I was listening to the experience, I was actually educated and inspired a lot. So since I'm almost the last panelist, I think we need a little bit of an energizer. So I thought I might give you guys a little Persian belly dance, but to get some of your attentions and get a little bit energized. But no, I'm joking. I'm not going to do that. I'm not going to.
Oh no, I was just almost looking forward to that.
I'm not going to traumatize people.
Don't hold back.
Oh my goodness. All right, maybe another time, but I'm not prepared. But again, thank you so much for the organizers, and it's been just amazing. I've been re-educated listening to all the panelists and experiences. As I said about the Persian belly dance, so I'm originally Persian from Iran, but I have spent over 18 years in Southeast Asia, mainly Malaysia, working on as a licensed counselor, and also working on community health clinic. So I'm just going to share my perspective, international perspective on the socio-financial and economical issues when it comes to HIV and AIDS. So it was about 2011 that I was appointed by this one of the eldest NGOs in Malaysia called PT Foundation to set up a community-based clinic. And our job was to provide health services, counseling, and HIV rapid test and pre and post-test counseling to the community members. The main challenge was that what are we going to do to bring people to the clinic and provide these services? And just following that thread, following that line of action, we had to learn the main challenges that the community members are facing and what is keeping them away from seeking health services. So, Martha, if you don't mind, we can go to the next slide, please. So some of the challenges that I would like to share with you guys, based on the experiences and stories that we've been through, and also backed by a lot of research is done in Malaysia. The main ones was always the systematic stigma and discrimination. Like, the discrimination is always there. And when I was listening to the stories shared by other panelists, I was thinking to myself, oh my goodness, the distance is so much, but it's just the things are the stories are so similar. We discriminate, we stigmatize based on the things we don't understand, based on the things that are alien or new to us, or just simply they're different. And it can be based on sex, gender, race, ethnicity, and nationality. That's what we do all over the world, but just the similarity was actually really striking to me. And this, I mean, when it comes to HIV and AIDS, so there is a big stigma attached to it, right? It's a moral issue. HIV, and if you have HIV, there is this big moral stigma attached to it, which can be related to your gender, sexuality, or sex worker, or even injecting drug users. So none of them are accepted in the society by people, as well as the government and the policy makers there. So that is one of the biggest challenges, and it limits people. They are marginalized, criminalized, and even demonized and stigmatized in Southeast Asia, particularly in Malaysian society. So as you guys may know, that Malaysia is predominantly a Muslim country, but we had the similar experience in Indonesia and also the Philippines, and also some other southeastern countries based on different values and different ways of thinking and viewing that. Family and cultural values has definitely one of the big impacts when it comes to the issues that our community is facing. It affects their self-esteem and self-image, and eventually to their self-efficacy, what they can do, what they can perform. It actually, if you see, when we meet the community members, they have a very low self-esteem. And even sometimes when the job opportunities and employment is provided, they don't see themselves, so to say, deserving for that opportunity. So they always see themselves at the lowest part of the society, because that's what the family and the society has dictated them. This is what you are. And if you are this, then your worth is lowered. And also, educational system has a big part. So we have to look at the schools. What do they teach? How do they treat? And what values are they making? Actually, I remember it was about 2017 that Malaysian Minister of Education created a guideline. And that was it was crazy. Created a guideline, how to spot gay men. And they were very specific. Like, one of them, it was just unbelievable. One of them was, if you're a man, if you're wearing V-neck, or if you go to the gym and you have this passion for building muscle and stuff like that, and if you like to wear pink, this was crazy. And that shows, I think, that you can see what we were dealing with, right? That was issued by the Minister of Education in Malaysia somewhere around 2017. And that was just so mind-blowing then, and made our life even harder. So they were giving this kind of instruction to the families. So watch out for these signs. And if your son displays some of these on the list, you might be careful and go for some sort of counseling. So this is just beyond imagination. And also, I would like to address my conversation to the counselors, because I understand there are so many counselors and young counselors there. So the next challenge, one of the biggest one, was the government policies that actually limited everything for them, limited their access to government health services, which in Malaysia was free for the Malaysian citizens, but they were not feeling safe and comfortable to go there because there were no specific protocol to help them and support them. And also, when it comes to employment, there were so much limitations, like insurance policies, and also employers. There were not. They could just ask you. You have to do a HIV test. It's kind of compulsory in so many companies. And if they see your result, that's it. They don't have to give you a reason, and your employment appeal or request application is rejected. No explanations is required. So all of these created this kind of very anxious anxiety for the community members. So they don't want to go forward to get to grab that job opportunity, and that becomes one of the biggest challenge. And now, if you come to different populations, specifically injecting drug users or female and transgender sex workers, that was even worse. The stigma and discrimination among transgender individuals was even worse. Like, they could be judged just based on their appearance. Nothing else would be necessary for them. So, and as a matter of fact, they had to, lots of them, they had to go to sex work industry, which again, sex work is also illegal in Malaysia, and it's heavily criminalized. And once it's illegal, it opens so many avenues for abuse, and their safety and security is in great danger. So that was one of the things. So as you can see, the consequences was like education, like students, because they were stigmatized or discriminated against, they would drop out of school and they don't want to continue their education. And also, as you see, they don't want to seek health behaviors. It can be two things. One of the biggest factors that we found was, if I have to worry about what I'm going to eat tonight, I don't want to go get tested. I don't want to go get my medication. My priority, like the hierarchy of needs, right? Safety, shelter, food. That's the first thing I need. Health and other regular screening process always comes next. So when they were not economically and financially supported, they were not feeling safe about that. Health was always secondary. And I had actually two of my close friends that we were working together, and they just stopped taking medication, and they didn't say anything to anybody. And unfortunately, they passed on. But that even we didn't know. One of them was one of my colleagues that we were working in the same clinic, but because of depression, because of hopelessness, he stopped taking his medication. So some sort of a passive suicide. He stopped taking medication, and then that was it, and nobody could do anything about that. So this is not, Martha, can we go to next slide, please? So the challenges are not only, it's not like as a therapist, as a counselor, as a health provider, we can't just sit there and talk and it's going to be okay and give you hope. Action speaks louder. That needs to be changed. Things has to start being different. So when I was a master's student in university, I remember that we were approached to provide services to community members, particularly when it comes to HIV and AIDS. And I remember, and this is what I want to share with the counselors and counseling students. And I remember that my colleagues, a lot of my peers, they were picking and choosing what kind of people I like to help, what kind of area I want to do. And that was the moment that I realized, like, as a counselor, as a health provider, our job is to be able to provide help and support to everybody who needs it without discriminating. So the first thing that I would say, as a therapist, we need to address our own values first and see where our priorities lies and how open we are to provide services to community members. The things like addressing the stigma and discrimination, we need to be aware of our own values and be culturally aware, so that we can provide the same service to the community and the families and the society in general. One thing that we were doing in our clinic was to provide psychoeducation to general public and the group of volunteers that they would come in by creating some emotional and experiential exercise and practice for them, so they can feel and understand what the experience of another human being who might be just slightly different from them can be like. So build that kind of connection for them. We need to bring the society together, right? Because I always believe that this is not the community's problem, this is the society's problem for not being able to accept and tolerate what is different from them. Again, that because, like, for example, in Malaysian setting, they say, oh, HIV is not my concern. I'm a heterosexual male, so I don't have to worry about it. It's a gay or LGBTQ issue. But the reality was not, is a society issue, because we are ignorant about it. We're not accepting it. And it definitely concerns us as well. Also, advocating for policy changes, that's something that we had to do. I mean, I was a counselor and I ended up banging on the tables on the government lobbies and all the meetings, because as a counselor, what can we do? How much can we just comfort them? And they need to be a change. And employment is one of the biggest factors. Like, I don't have job, I don't have food, I don't have shelter. Why do I need counseling? So that was one of the things. So we started doing a lot of advocacy work, bringing the policymakers to create that change and support for the individuals. And again, as I mentioned, self-stigma was one of the issues as well, as a counselor and also as the individual, as the client in front of us. Because a lot of community members, they blame themselves. They actually found themselves, because still they have those belief system that they're not worthy. And this is a punishment. And that was something that we had to deal with. Like, they could be like a Christian or Muslim. And I mean, in my case, of the cases that we were handling in those scenarios, and they blamed themselves, and they viewed the disease and all the challenges as a punishment. And that was so difficult for us to bring them out of that depression and provide the opportunity and give them hope. And of course, addressing other mental issues. As I mentioned, suicidality and depression were one of the main ones among the individuals. Even if it was an active suicide ideation, they were passively suicidal. As I mentioned, like refusing to take medication or refusing to go for bodily checkup and medical checkups. So, and also the substance abuse, that was another big challenge that we were dealing with. Because again, drugs were prevalent, and especially in the past 10 years, methamphetamine has been the most predominantly among LGBTQ community, and which was, I think, because the whole psychological pressure and hopelessness would actually lead them towards, something to numb the pain or temporarily forget about the pain. And also, it was very much engaged during sexual activities like chemsex, which was because, and I did some work with the rehab work with the LGBT community who were engaged in the chemsex activity. And that was the thing, because I just want to be able to enjoy my sexual activity just without that voice in my head that you're a sinner, you're a bad person, just to shut it out and just make it quiet so I can just enjoy that. So
in America, we're not really allowed to talk about sex.
Oops, I'm sorry. Actually, not in Iran nor Malaysia. We're not allowed to talk about sex either. But actually, in Malaysia, we talked a lot about sex, even if they didn't like it. But we were really, I mean, I had amazing mentors, really bold, encouraging, and we did talk about sex. And I think we need. I remember one of the panelists mentioned we need to have the conversation. We need to talk about it. It's the elephant in the room, right?
Right, right. Well, so this has been really, really amazing. And I know that we were supposed to move on to Liza, who is gonna, give us an idea about what is going on, what we can do and so on. But maybe I would like for us to really bring together what we have been talking about in terms of two things. You've been talking directly to counselors, and we've been talking about services. I would like maybe each of you to just spend, like a minute speaking about everything that you've talked about, right? You've talked about people living with HIV facing different kinds of maybe progressing with cognitive impairment. We've talked about severe depression, about people living with HIV for all the various things, familial things, stigma and discrimination. My son bought a pink sweatshirt, Nike sweatshirt the other day. I don't know if I should be worried. We've talked about just different things that people are experiencing. Can each of you sort of just tell me what is the one service? What is the one service that you can add to current vocational and rehabilitation specifically for people living with HIV, just based on everything that you've talked about? What are the one or two services that you could add that is not there, that is unique to these challenges that you've talked about, that we can consider advocating for? I think Harold Phillips talked about we need to advocate. What is one or two services, especially in terms of counseling or rehabilitation, that we could add or encourage counselors and rehab to add to the services that we have?
May I? I mean,
Yes, and then I'll go ahead. Go
my
ahead.
engine's still hot, so I might just carry
Yes,
on.
go ahead. Go ahead.
Okay. So, I mean, in the Malaysian setting, I'm not sure about the US setting. I can't speak for that. But in Malaysian setting, one of the most important things that it was just starting to happen was to like creating some workshop, to teaching them some skills so they can increase their employabilities in society. I mean, especially when we're talking about the female and transgender sex workers, that was one of the main ones. The middle-aged group, to teach them and giving them some workshop to increase their employability so they can learn certain skills, basic, but to help them, and also teaching them about small social enterprises so they can enter into workforce. And of course, I would say also another thing that I would also advocate for is to create more awareness. Because again, as I say, this is not that community, particularly issue alone. It's everybody's. We have to bring everybody in. And also the power of allyship. We need to promote that by psychoeducation and bringing in more people. This is not just a PLHIV group concern. We need to bring the other people in society to support them. We're all together in this. So this is not the battle that we can win alone. We have to all join forces together. Thank you so much.
Thank you. Thank you, Fabord.
If I could just chime in, just a perspective. I think sometimes all these different issues, mental health, poverty, stigma, sometimes are thought of, we tend to silo our thinking and our services. So one concern I have is that people might say, oh, well, you need to address all of that before you can think of employment, or not seeing it as a part of an integrated whole. So if we want to address stigma, I think Mr. Phillips talked about this, how employment can reduce stigma. And even when to try to motivate people, like if someone's depressed because of the stigma, because of history of abuse, I think what I would add just as a need is trauma-informed vocational services and not trying to chop people into silos like, oh, I'm just going to give you mental health. And when I think you're good enough or recovered enough from the mental health, then I'll refer you for vocational services. I mean, there is a continuum and a challenge in that, but I think even when you're providing mental health, to never forget the importance of employment. And knowing that there's many different kinds of rehabilitation models that are designed for people with psychiatric or mental health illnesses that can also be integrated along. And I think just learning a little bit more, and it's really how you think of a human being. And I just really like also what Farbad's saying is that, and Sungwon with the advocacy, you have to do both, help the person and address the barriers in society.
Yep. I don't know if Sagwad or Tia, you have anything to add. In the US, we have seen all these sort of anti-LGBTQ policies coming across. And so counselors, vocational rehab are working against governments, local governments that make it very hard to provide affirming care. Can any one of you just comment on, what can that counselor do in spite of the fact that they're not being allowed to be recognizing or affirming of certain identities?
I'm not the expert in that, but probably Sungwoong would be able to say that. Yeah, to answer that question,
Okay.
Sungwoong,
Yeah. Okay. Yeah. So I was thinking like the questions like what would be the something that I can add on, and Farbad mentioned about the Malaysia, so I was also reminding of my years in South Korea too, and but like both of countries, of course, like in South Korea is also not in an ideal situation. We have a like lack of services, like strong stigma both in LGBTQ plus community and also HIV. And of course, like it's getting worse in US. And so I was thinking more on an accessibility part. So we talked about some services targeting like people living with HIV, like some part we link with the like vocational rehab, like employment focused interventions. And of course, like we can do it in the counseling session. We can get in services at the same time. We can also continue on and conversation in the sessions, even though if you're a counselor, that does not mean that you cannot talk about employment and career development. Of course, you can integrate those pieces into your clinic, like, and talk about it, and that can be highly also connected with your client's mental health and a lot of things. But the thing that I was thinking was there's some services out there, but like there's always some issues not linking, like there's always accessibility issues going on, I think, like for a lot of reasons. Sometimes it's because of the transportation, sometimes it's about like stigma, like them helping like some barriers going on to be connected with other people living with HIV. So kind of like pushing them to stay in a closet, or those are things I think. So some maybe outreach or like providing more information or like having some partnership with the community to build a strong like connections with the service providers and the people living in the community. So I think there's a lot of layers I think should be add more on, like from the like continuum, like from the service provider to the people who needs the services. Unless we have those bridges, it's hard to provide the services to the people who really need that pieces. So I think counselors can have that kind of role in the middle, because we are meeting individually, and people who might you feel shame about like sharing these stories, but they can be a kind of like liaison if they can do the active role. So that can be also one part, but of course a lot of outreach I think we need.
Yeah. So before I hand over to Liza, and I am watching for questions after Liza speaks, I would really implore you to ask any questions. I think a key word that you've mentioned, Sagwan, is bridging. And one of the things that I have experienced personally is that there is very few bridges between the people who do the research and the people who can make these recommendations and are actually in the community with the lived experience. You know, we heard from our first panel, I think it was Jasmine, who actually said she's a PI on the research that is being done. I've had experiences also working with researchers, but I really do believe as a community, this is a place where we as people living with HIV need to kind of disrupt some of the things that are concluded in research about us without us, and that we are sort of the best people to advise on some of the interventions. But we cannot participate if we don't have a PhD and we don't have a master's. We're not allowed to be on some of those research panels. But I dare say that with our lived experience, 20 years for me, it means I actually have maybe 4 or 5 PhDs in my lived experience. And what we can hope for is that as researchers are making some of these conclusions, that they're also inviting the community to come and be PIs, you know, to come and be equal partners in analyzing and understanding the research and what can happen thereafter. Because I really believe that has been the bridge. There is amazing, amazing research out there that we have seen, and Liza's about to talk about what we're looking at. But you know, some of it is not translating into policy, is not translating into services. The CDC medical monitoring project, something that is released, I think it's almost every year, and we'll put a link to it in the community. The most recent one, it talked about the estimated prevalence of unstable housing and homelessness among all persons diagnosed with HIV was 17%. 15% experienced unstable housing and 8% experienced homelessness in the previous year. And as Harold was saying, this is about 2 or 3 years old. Approximately 16% experienced hunger or food insecurity. But a staggering, and I mean a staggering 39% were unemployed or unable to work. That's among us people living with HIV. And it sounds like we know from the research why this is the case, right? We know about the stigma and discrimination. We know about all the depression and mental health, but you know, how is that translating into policy and services? So just giving people food for thought, but asking Liza to talk to us about future recommendations and policy, and then we can open it up.
Yeah, so I realize the time is short. So if we could go to the next slide, I want to leave some time for folks. And so one thing I just want to follow up with what Martha's saying about the importance of the voice of people living with HIV and research. So what I have here is what we plan to do as the research working group moving forward. And I really want to emphasize that as a core value of the National Working Positive Coalition. In fact, when we got started in 2003, I think we spent a year just trying to work out our vision and mission statement to make sure we don't take funding and things that would not be consistent with our vision and values. And one of our core visions is nothing about us without us, and the idea that all research should have some level of participatory action or input. So when I talk about the research working group, you might think, oh, that's not for me because I'm not a researcher. But we actually have people in the research working group who are not technically quote unquote researchers or don't have PhDs but represent core groups of people who are most impacted by HIV. So people living with HIV, people who have histories of incarceration or poverty, or all the kind of social determinants of health that we're talking about. So it is a core value of the NWPC to work in collaboration and to be primarily led by the voices of people living with HIV. So what we plan to do is to continue our monthly research working group meetings, and here you can come and hear. Sometimes we have short presentations by different members of the group. We might hear from people, hey, these are the topics that I think you should be prioritizing, from non-researchers. And we work to foster collaborations by having these kinds of dialogues. We're looking to develop more items for the medical monitoring project that Martha just mentioned, because just are you employed or not is not enough information to understand the complexity of employment needs. We're also working with the Pennsylvania Ad Hoc Committee on HIV and employment to get a brief assessment of employment needs in Pennsylvania. And also continuing work. Dr. Khan mentioned, the work in Canada with the Ontario HIV treatment network. We have and then this team is working on completing a system. We set new goals and we continue to evolve, and we're constantly looking for input and feedback as to what the priority should be, and then try to help facilitate that. So I'll stop there because I realize we just have 10 minutes and I want to make sure there's time for questions.
Well, thank you, Eliza. Thank you to the whole panel. I'll watch out for any comments and questions in the chat, and of course, we'll be sharing the slides. But let me hand over to Mark to bring us around.
Thank you so much to all of you, to Jen, to Liza, to Farbad, to Atia, to Sangwan. Thank you so much for that excellent, excellent work, an excellent panel. I'm seeing that we are getting awfully close to 1 o'clock. So if we could get the next slide, please. I do want to move us towards closing out. One, I want to implore everyone still with us to please click on the link in chat, use the QR code on the screen right now, and get access our brief training evaluation survey. It will be a tremendous contribution in support of us and this event and this project. We would so greatly appreciate that being done. Indeed, if someone is seeking the CEUs, that certificate will require that you complete the evaluation, and we greatly appreciate everyone doing that. If we could just skip quickly to the next slide. I did want to share this contact information for the National Working Positive Coalition. We'd be extremely excited to be connected with some folks who might be interested in one of our working groups and being connected with our work in some way, in participating potentially as a trainer in the future yourselves. We're very much interested in reaching out and connecting across service systems and expertise. If we could go to the next slide, I just want to express my and our very deep appreciation of North Carolina Central University, the Counselor Education Department. I want to especially thank Lavette Scott, who very single-handedly made it possible to bring us in for the first time last year, and then now for a second time this year to collaborate. It's been a tremendous, wonderful, deeply rewarding and very powerful experience. And we're so grateful to Lavette and to Kyla Kurian, who has picked up the baton this year in such an incredibly beautiful and meaningful way. And we're so thankful to all of the folks who've contributed behind the scenes, in the panels, and in as speakers today. During the course of this webinar, I have now obtained permissions from Harold Phillips to share his slides, so we can share the slides from the full day with everyone who's attended, and will do so, and very much look forward to the opportunity for future connection and collaboration as we collectively work to strengthen responses to the employment needs of people living with or at greater vulnerability to HIV. Thank you, everyone, so much. I'm now very much appreciatively handing the baton over to our colleagues at North Carolina Central University, Dr. Kyla Kurian.
Thank you so much, Mark, for our collaboration together. We want to thank Heather, who's behind the scenes doing the communication kind of work. She's been phenomenal. Also want to thank Dr. Jenny Barrow, who's a part of the NCCU Counselor Education team, as she has been working with Dr. Scott and I to kind of get this up so everyone can participate. Dr. Scott is not able to be here. She had to be somewhere else, but she wanted to be here at the end. But just a great thanks to you too, Mark, for working with you, your dedication, the collaboration, your ideas, your energy in this area is very infectious. You make a great impact. There's no doubt. I can tell just by hearing what people are saying. So thank you all so much to the panelists for all of your heartfelt sharing. You know, it does take a lot to share. And it's so valuable for our counselor education students. I've seen here, providers. We've had what I think international representation from Canada, Guam, and Iran. We are so glad that we're able to reach around the world. That's so wonderful to have all of you here and participate. And so hope that you all continue to advocate and educate others about people who are living with HIV, and that you can make a difference in the lives of those people. If you all have any questions, feel free to ask at this time. But otherwise, we bid you adieu and have a wonderful, fabulous weekend. Thank you all so very much on behalf of North Carolina Central's Counselor Education Program.
Thank you so much, Dr. Curry. And I see we have one question, one hand raised. Rodell Desamu Thorpe.
Yes, can you hear me, Mark?
I sure can.
Hello, everyone, and thanks for a very informative session today. In the interest of full disclosure, I am with the Medical Monitoring Project. I work for the CDC, and I had a few issues logging on. I was 30 minutes late, but I stayed on, and it was refreshing to hear, and also the shortfalls of the data that we collect. But what we do typically, and that's my day-to-day work, is we have the 23 project areas lean on their community advisory board and provider advisory board. So that's how we come up with our questions. And whenever we're revising the questionnaire, because it's public facing, we encourage input so that we can have that. Because most recently, because of the work that we did, shameless plug, I would say, you know, measures of instability, unstable housing, and stigma, they were included in the revised National HIV/AIDS strategy. So I would say just lean on those project areas. And again, it's public facing, so you can see the project areas that are represented that paint the national picture, and encourage them to submit questions. We welcome them. Thank you very much again. I appreciate the time, and I will take it back to the group. Absolutely.
Thank you so much, Rodell. Thank you so much for joining us. We did have some preliminary discussions and communication and interaction with members of the team at MMP, at the CDC, working on the MMP, and we very much continue to be very interested in seeing that continue, and would like to be involved and helpful in any way possible to better flesh out the items that can capture the real lived experience related to employment and employment needs. Thanks so much.
You're welcome. Thank you.
Thank you, everybody. I think we're zooming in right. We're even a minute or two on time. I'm not going anywhere in case anyone has any additional needs for questions and comments. we're not going to close out till 1 o'clock. Anybody else? Am I missing anything?
Mark, I can hang on too, so we can allow for any conversations too. So I'll hang around for another 5 minutes or so.
Awesome. Thank you, everybody. And a special thanks to each and every one of you taking a moment to complete our evaluation. It's an extremely meaningful contribution in support of this work. Greatly appreciate it.